So we're really here today to talk about patient power in the NHS and the 10-year plan. And we'd really like to focus the conversation on how patients can be empowered more broadly instead of down party political lines. So we want to think about, what does true person-centred care look like? How should the DHSC Directorate engage with professionals and patients across the system? And what does embedding patient experience in the NHS look like? What are the opportunities, risks, and challenges associated with implementing some of the initiatives outlined in the 10-year plan? And what do we need to consider to turn the 10-year plan into a reality? So I'm going to start by introducing myself. So I'm the chairing this session. I'm Dr. Rageshri Dhairyawan. I'm a consultant in sexual health and HIV medicine at Barts Health NHS Trust in East London. I'm a researcher and a writer. I'm author of the book Unheard, the Medical Practice of Silencing, which looks at how historically patient voices have been silenced in healthcare and research and what we can do about it. We've got a really amazing panel with us today. So to introduce them, we have Cheryl Tackey, who's chair of the Patient Partner Voice Forum at the National Cancer Programme for NHS England. We've got Rachel Power, Chief Executive of the Patients Association, which, as you know, is an independent charity campaigning for improvements in health and social care for patients. And we've got Chris Graham, Chief Executive of PICA, a health and social care charity with expertise in person-centred care. And this webinar has been organised by the Patients Association with PICA. So what we're going to do is we're going to start off with a very brief poll. So I'll just wait for that to come on. So this is the poll. Patient voices. How much do you feel patient voice is influencing NHS decisions right now? So please make a single choice right now, and then we'll have a quick look at the results before we go on with the webinar. Right, so we have some results. So 75% of you have voted. So no one has said a great deal. 28% have said somewhat. 49% have said very little. 16% not at all, and 7% unsure. So I think that's a really, really interesting start to this webinar. So thank you very much for that. So what we're going to do is we're going to start with some opening remarks from each panelist, and then we're going to have a facilitated discussion with them where I'll be asking them some questions. And then at the end, there's an opportunity for you guys to ask questions as well. So as I said, please do put your questions in the Q&A option in the chat. So I'm going to hand over to the panelists to start their opening questions. I've realised that we actually haven't said the order of who that's going to be. So I might do it in the order of how I did the introductions, if that's okay. So Sheriff, is that okay if I start with you and then Rachel and then Chris?
Absolutely fine, no pressure whatsoever. So good morning, everyone. I recognise a couple of names that had come up on the welcome chat. So it's lovely to see so many people this morning. For those of you who've just joined, I know Rageshri just explained who I was, but my name's Cheryl Tackey. I'm currently the chair of the Patient Partner Voice Forum for the NHS England National Cancer Plan. I also do one day a week with the South East London Cancer Alliance as a lived experience patient partner. So it's lovely to be here, as I've said. Thank you for inviting me to share my views on some of the things that we've been talking about. The polls just kind of indicated already that people really don't necessarily feel that they have power as patients. So it's a great segue to start this whole conversation. I think for me, I wouldn't necessarily use the word power. I think right now patients have some form of influence rather than power. And I think when I use that word influence, it means that we still have some room around the table. We're able to bring our voices to some conversations, but really and truly power indicates that we have autonomy, that we have control, that we have complete indication as to how we want things to work. And that's not necessarily the case right now. I think because the patient's voice is still prominent, things are changing slowly. It is happening, and I hope that will continue to be the case. But I think the fact that over 11,000 patients, carers took part in the call of the 10-year health plan to actually bring their voice, and shows just how much care and passion that they have for this whole cause and what that means to them, and what it actually, how it affects them as well as patients. I think patient representation, engagement in the last year or so, from what I've seen, and I've been here, well, I'm still undergoing treatment. I had treatment just yesterday, actually. But that just indicates just when patients are involved, how much it can make a difference. And I think we have still got some way to go. But I think in the last year, I would say that I'm seeing more and more of that patient engagement role becoming more prominent in different communities, in different departments. And I hope that that continues to be the case. I think the other thing that I'd like to bring my reflection on is that patient voice, choice and experience is really, really important. And it's really important to be as part of the NHS reform. I think that at the moment, the answer lies in the title, right? So we are lived experience patient partners. That's what we're called. So if we are called lived experience, then our perspective on what is actually happening on the ground really means something to us. And I think what's happening is that we know what is working and we know what isn't working. Like I said, I was having treatment yesterday, and at the same time, because I have my strategic head on, I know what my pathway is supposed to look like. But when it doesn't quite happen that way, I'm able to bring that to their attention. Not everyone can do that, and I'm aware of that. But I think I'm blessed to be able to sit around those strategic tables, the leadership tables in the NHS and the Cancer Alliance meetings. And I can categorically say that I think being able to collect and analyze data is one thing, but actually then turn that into an action is another thing. We don't always know. For example, I'll give you a case of how important voice is when we talk about the DNA or the did not attend. There's a whole plethora of reasons why that patient didn't come up. But from a data perspective or from a performance perspective, it just looks like the patient couldn't be bothered or they've forgotten. But actually, it could be they couldn't get there transport-wise. Something could have come up. They might also be a carer. They could have been sick on that particular day. So I think for me, it's about really looking at, as part of the NHS reform, a patient voice is actually about being able to do a deeper dive, really listen, really hear, and really understand what the patient is going through, rather than just look at performance data and analytics. It's all relevant, but I think the human intelligence part of that is gone. And I think finally, what I'd like to say, just as a couple of keynote things, is that we know that the 10-year plan is very, very ambitious. What is important now is how that's now implemented. And we've seen that the indication for Cancer Alliances to be, I think the heavy lifting is now on Cancer Alliances to do a lot of that work that we've seen in parts of the NHS, the 10-year plan. But I think, again, even though that's positive from a Cancer Alliance perspective and what we're being asked to do, Cancer Alliances they know their demographic, but we also know that there is difference between the Cancer Alliances. Some are small, some are large. And I think what we need to do is just make sure that when we are working together, that we make sure that even though those Cancer Alliances are working at different levels, that the health inequalities, it doesn't go shot to pot, really, is what I would say. I don't want to see that increase, but I think at the moment, I would say that we're doing pretty well, but definitely not necessarily a power to the patients right now, just more of an influence.
Thanks so much, Cheryl. Really appreciate your insights there. Okay, I'm going to move on to Rachel.
Completely forgot to unmute myself. Cheryl, thank you. That was really brilliant. So I'm Rachel. I'm the Chief Executive of the Patients Association. So thank you all for being here. So for me, I just reflecting on some of the things you said, Cheryl, and I agree with you. And I think the issue around the do not attend, the missed appointments, so much more could be going into missed appointments. And I find, there are people in the system who really are curious about what that happens. And I suppose a year on from the 10-year health plan, I want to see a lot more curiosity to understand what's happening in those communities that we're not really working with as much as we should be in the system, to understand their voice. And I completely agree with you. So it's a year that since the 10-year health plan was published. And I suppose from patient association and what we hear, the honest answer to has anything changed? That on paper, yes, there's some good stuff. There's a great ambition in there. I get that. But in people's actual experience of care, probably not so much. We still, and it's great that you're having, and there are pockets where it's really good, and we know the frontline staff are working really hard. So this is more strategic. So our patient experience survey this year, which we launched a couple of months ago, 7 in 10 people told us they weren't even asked what mattered to them in their care. And that's really important. And only 2 in 5 felt like an equal partner in decisions about their own treatment. So we need to grow that good practice that you've experienced, Cheryl, and make that move across the board. So when we talk about power to the people, as you said, I'm not sure that many patients are feeling that right now. And I don't mean that as criticism of the ambition. I really don't. The ambition is right. The question is whether the infrastructure is ready to deliver what's currently being built. And of course, we've also going through a pretty massive reform in the closure of NHS, and we're going to come on to that, the closure of NHS England, and the impact that that's having on people, and the changes at ICB level, and the changes of patient voice, which I'll come on to. But things are moving. We know now that the interviews have happened or are happening for the National Director of Patient Experience, and that's a good move. We know, I think my biggest thing is underlying all of that is we still don't have a clear delivery plan. And of course, we're having huge changes now at a political level as well. And so we have a great vision. And I think that's important. But I think there isn't really a shared yardstick about what on track means in the 10-year health plan and where it's going. And I think for me, like if you look at some of the stuff in there, PROMs, and universal patient experience measures, not till 2029, NHS app, a 2028 commitment. But what we live and breathe every day in the patient association is what's happening today. And I think that's back to what you were talking about, Cheryl, in terms of the curiosity and what are people experiencing in today's appointment, today's decision about their treatments. And for me, the test of the plan and where we're at now isn't really about the headline commitments. It's about whether patient voice is truly getting embedded into how decisions are actually being made, and that we move on. And I still find myself in meetings where things are quite developed, and you're like, where's the power to the patient here? Where, page 161 of the 10-year health plan, I know the page number, it talks about designing and delivering with patients. And I'm not sure that we have the culture. And in the midst of all this reorganization, I kind of understand that too. So just finishing, I think we'll get onto it, but my big question as part of my introduction is what will happen to the independent voice? We have Health Watch being abolished and going through and the governor model changes, and what replaces that. And I also want to understand more what choice means in practice, because the 10-year plan talks a lot about patient choice. And I think it needs to be more than just policy document at this moment in time. And we've obviously done quite a lot of work on it. So lots more to come. So exciting things happening. But I think today, right now, patients aren't seeing the difference.
Thank you, Rachel. That was really, really helpful and interesting to set some of that landscape out as well. Moving on to Chris.
Yep, and I can find it on mute button and everything. So thanks very much for the opportunity to talk today. Really glad to be involved in this session. And I guess coming into it, I was a little worried that I was going to be a contrarian talking about perceived problems and so on. But then we do the poll at the start, and 65% of people say very little or not at all as how much patients are influencing NHS today. And I feel like maybe I'm in a safer audience than I expected. So that's encouraging for me as a starting point. But also I need to make sure I'm not just repeating what others have said, because Cheryl and Rachel have made excellent points about the role of patients and the power that they have already. And I think Rachel particularly has talked about independent voice, which is something that is really, really important to me. So I'm going to try and give a balanced perspective of how I see things, and what I think needs to change to do better. I guess I'll start by trying to answer the exam question: how much power do patients actually have in the NHS? And I think more than they once did, which is positive. Rather less than the system sometimes pretends, and much, much less than they really should in a system that strives to be person-centered. And I think when I think about the positives of things that have changed, they're all sorts of fused with that sense of we've not quite made it to where we need to be. So whereas patient power increased, patients have more choice, in theory at least, but often that choice is limited in practice. You may find yourself choosing between providers, but where waiting lists mean that the choice is really no choice at all. You can access information far more readily, providing you're on the internet and you're comfortable using it. You can give feedback, join patient participation groups, and get involved in citizens panels or public consultations. But you might come away thinking that things have been brought to you quite late, or that not much has changed as a result of your input. So at best, there's a real tangible sense of involvement mattering, but all too often, I think it doesn't quite hit the mark. Because for most people, I think that the NHS still feels like a system that largely decides things on your behalf rather than in partnership with you. There's still a sort of benign paternalism that can keep patients at arm's length from the really important decisions. The system can be very happy to ask people their opinion, but not always to trust them to make choices for themselves. And that's at odds with the commitment on page 22 of the 10-year health plan. I've got the numbers seared into my head too, that it has only one core purpose: to put power in patients' hands. And the way I see that is a really radical statement, one that I really value. And I think it's a great ambition for the health service. But if we want to make it a reality, we've got to move a lot faster and be braver than we are today. So I want to focus a little bit on the role of patient voice and experience and how that's being used, because one of the key ways in which the plan talks about transferring power is by strengthening the role of patient voice. But to make sense of that, I think we first have to understand a seeming paradox, that right now in 2026, we have never known more about patients' experiences of care than we do today. We have an absolute wealth of surveys and data collection. Many of you will be familiar with the NHS Friends and Family Test. That alone collects around 2 million responses a month, every single month. That's a huge volume of data. But despite this, the data from the most robust of those collections shows that in many ways and in many places, care is really no more person-centered today than it was 20 years ago. People don't feel more involved. As Rachel said, many people don't even get asked what matters to them about their care. So collecting more and more data doesn't automatically make for better care unless the whole system is set up to listen and respond to the feedback that it gets. And for me, that gets to the fundamental point of why patient voice is so important, is because patients see things that organisations and professionals don't. And if you look at all of the major failures in NHS care over the 25 years, look at all of the many reports, including the Amos and Ockenden maternity reports of the last week or so, a recurring theme is that patients and families knew something was wrong before anyone else did. They spotted risks, they raised concerns, they asked for change. The problem wasn't that patients didn't raise their voice. The problem was that no one was listening. So one of the key ideas in the 10-year plan is that technology is going to help amplify the patient voice. There'll be more feedback through the NHS app. It'll be processed with AI at a greater volume, and patients will be given more information through the app in turn. Now, I'm not a Luddite. I'm really in favour of better use of technology and information, but I worry that there's a misdiagnosis of the core problem here. The NHS doesn't lack experience data. It doesn't lack patient feedback and insight. It has vast quantities of it already. The problem is that it's not set up as a system to listen and respond in a meaningful way. The plan's response to that is to bring patient experience in-house. So as Rachel said, creating a new director of patient experience, but at the same time doing away with Health England and its local bodies. The idea is to give patient voice more status and control, but I see that as being at the cost of a loss of independence. And if people have had really awful experiences of care, will they be as open to sharing those with the departments as they would be with independent local bodies that exist to support them? I'm also worried that the shift towards collecting more and more data online might further marginalise those people who are most vulnerable, most isolated, and most disconnected. And if that happens, that's not real power sharing, at least not the kind that breaks down class divides and gives power to those who lack it. So we shouldn't confuse data collection with patient voice. Gathering millions of pieces of feedback isn't the same as involving people in decisions or shifting power. Listening requires action and not just measurement. And very briefly, the kind of things I think need to happen to make that a reality are getting more comfortable with using voice at every level of the health system. So I'd like to see more emphasis on executive level accountability for patient experience within providers. Very few have board level executive directors of patient experience. That's my timer telling me to stop. I'd like to see more support for patient experience teams within organisations. They often lack cultural capital. They often lack training and resources. They need to be given more status and more power to change things for the benefit of patients. And I'd like to see a recognition of the power balances that need to be overcome. Not all patients start with equal power. Some are digitally excluded or have been harmed by health services, and they need independent advocacy to help them raise their voices. So I will stop because I am over time. I really hope I don't sound too negative. I'm completely behind the ambition. I'm all for power to the patients. I just want to see delivery organised around the right things, because I think the real question for patient power isn't whether the NHS is listening, it's whether it's ready and able to act on what it hears. Thanks.
Thanks so much, Chris. That was really powerful and again brought together a lot of themes that we're going to talk about more today. So thank you all for your opening remarks. It really sets the scene brilliantly for us. Reminder to people who are watching, if you want to put your questions, please put them into the Q&A. I think we're going to move on now to a bit of a discussion between me and the panelists. And then, as I said, there's opportunities to answer questions from the audience later. So it's going to be in the same order as we've been doing all this time. So Cheryl, I'm going to start off with a question for you. It's quite a broad question. What learnings have you taken from your role as Patient Partner Voice Forum Chair?
Gosh, there's so much positivity I could bring to that. But I think one of the things that I can honestly say is that listen, I've come in at a time when I had predecessors, Wynne and Mike, were part of that whole Patient Partner Voice Forum and setting it up. But I think for me, it's hope. When you're sitting amongst other patients, it's not just about us going for treatment. There is a golden thread of hope between patients that you can't measure it. We go through a system and we might not necessarily have the best care, but we meet individuals. I can't not talk about staff, right? The staff are up against lots and lots of constraints. And I think seeing all of that work happening with staff and that compatibility with the patients to want to get things better, for me, that's one of the takeaways that I've got, that there's hope from the patients as well as the staff and wanting to bring those things together. I think the other thing that I can say is we don't just turn up for tea, coffee and biscuits, right? We don't become patient partners for no reason. Something has happened within our care that we want to correct, that we want to change. So it's not always a negative reason why we join. Sometimes it is, but we process that negativity into positivity. We want to see that change. And I think when you are amongst the right people, great things can happen. And it's always, and sometimes it's the smaller things that make the bigger difference. It's not always about I get it, we need the digital stuff, but we can't also leave people behind. And I think my role as part of the chair, and what the Patient Partner Voices Forum does, is that we bring that emotional intelligence back to where it needs to be. We have the great, executive rooms and the leadership rooms, and we need them. But our role, and my role as chair, is to actually make it real again. So when you're talking about data and performance and targets, there are people involved in that. There is human intelligence that we are losing behind. And I think also from my role as PPV is administration of care, for me, is a massive thing. We are still seeing letters coming after people have attended their appointments. So reminding that we're not even getting the basics right, but we're moving on to the digitally empowered stuff is a real thing for me that I've seen and learned from my role. So yeah, lots of learnings. We don't have enough time to talk about all of them, but there are the things that I wanted to bring forward to that.
Thanks very much, Cheryl. And I love that idea of hope. And you're right, people are doing it for a purpose, aren't they? We can't ignore that. Yeah. Okay. Moving on. So Rachel, what would you would have liked to have seen in the 10-year plan that isn't there?
Very good question. I just want to build on Charles' hope piece, and maybe that is something that is missing in the 10-year health plan. That hope that we, if we really give power to patients, if we really genuinely have a culture that staff are allowed to do this, because there is something about the leadership culture as well. And that staff have the time and the experience to do this. That would implement that bit of the 10-year plan. But I suppose, I think I discussed the lack of a delivery plan, and Chris has picked up on that as well. I suppose the one area that really surprised me was that if we are going to do power to patients and give patients power, that shared decision making, that whole co-production, shared decision making, whatever word you use, partnership, wasn't as present in the plan as I'd like to have seen it. We know that that's one of the most evidenced ways to actually shift power to patients, to genuinely involve patients in decisions about their care and their treatment, and not kind of after the effect. So you think about shared decision making, you think about consent, and I think, and maybe that's because it is a 10-year health plan. It focused much more on structural. It focused much more on what the app could do for us. It's focused much more on, and I'm just picking up on Chris's point around, the role of AI. And again, I'm not a Luddite, but it's not going to, digital and AI are not going to solve the problems about patients not being listened to. That is a structural thing, and that's something that has to happen. And then some fabulous stuff can happen with digital and AI. And I think maybe that the plan as well didn't deal with the inequity question. It did in the introduction. It does promise that it will deal with it. But if you look at digital, we've got three we've got digital, very digitally enabled people. We've got people who are confident but need more support. So the work that's happening in libraries at the moment around digital. And then you have people, living in coastal areas, rural areas where Wi-Fi is not great, where actually they can't afford Wi-Fi in their home in certain areas, cost of living, all of that needs to be addressed a bit more. And we have a huge focus on elective recovery, and somebody just put in the chat there, we still have a huge problem with the access. And if you can't get in at the front door of the NHS, be that through, where primary care, if you can't get in there, then elective's not really your issue. Your issue is getting your diagnostic and getting listened to. So I think the third is kind of the accountability more broadly within the plan. I would like to have seen how progress will be measured, and how progress will be much more measured through outcomes for patients. And I don't think we're very clear about what's going to happen with the loss of the independent voice, but I think we'll come to that in a further question, so I'm not going to go into that right now. And I would like to see a lot more. I would have liked to see a lot more in the plan who, that attention to people who find it the hardest to be heard. Those people who just do not have absolutely no power in the system right now. And what are we doing about that? Because the people furthest from power in the system risk then being further away from the benefits that the plan may have in time as it's implemented.
Great, thank you so much, Rachel. Again, really, really comprehensive about all the things that should have been in there that aren't. I'm going to move on to Chris now. So the plan includes patient-powered payments. Chris, what do you think needs to be considered as part of a pilot for these power payments?
Yeah, so for anyone who's not familiar, patient power payments are a commitment in the 10-year health plan to create a, quote, new financial flow that links patient voice to payment for providers. And basically the idea is that patients who've been treated in a secondary care provider like a hospital will be asked whether they think that that provider should get the full funding for their care, or whether 10% of it should be held back and redirected into a regional improvement fund. And the idea is that this gives people a direct voice in part of the funding decision for organisations, which is a really direct way of having patients influence funding. It's a really interesting idea in practice, but I think that in theory, but I think the concern about it in practice is there's very limited and inconsistent evidence around the use of patient-reported data in pay-for-performance schemes. So this is a bit of a departure, and that means there are a lot of challenges and questions that need to be overcome. We've actually published a briefing on our website that covers this in more detail, but in summary, I think there are a mix of methodological challenges, conceptual challenges, and then really practical issues around how this works. On the methodological side, it's really, really important that if you're going to use patient-reported data to determine pay for performance, then that data needs to be pretty unimpeachable in its quality and reliability. Otherwise, I think just drive a wedge between patients and providers, where there's the potential to question the validity of the feedback. So we need really clear questions, a really consistent methodology for getting the feedback, and one that's representative and gives everyone a voice, not just those who are easy to contact. That's already quite a big ask, in my opinion. But then if you want to incentivize the right things, then what we know from wider work around pay for performance is that you need to have a really clear, direct, tangible link between the payment mechanism and a behavior that you want to change. So, if you want clinicians to communicate better, if you want hospital consultants to give clearer information to people before they're discharged, then one way to do that might be to have a system that says, did your consultant communicate clearly with you? If they did, we'll make a payment based on this. At the moment, we understand that's not quite how it works. Instead, the idea is that people will simply be asked whether the funding should be allocated, which is very clear, very direct, but very subjective, because people will make that decision for different reasons. I might be satisfied with my care because I got parked easily and I was in and out for my reasonably routine procedure, but my grandmother might be more concerned about whether her condition's been treated properly, whether she's been given the right medication, whether she's had a fall in hospital and been treated poorly. These are very, very different issues that merit a different response, and treating them as one size fits all, probably not right. So I think there's some refinement needed to make this a really actionable tool for not only linking patient voice to payments, but allowing patients to say what about their experience matters to them, and why it should be linked to payments. The concern is that otherwise it gives patients a role, but not an ability to be informed or to have a meaningful stake in it. So those are the kind of concerns that I have. I very much hope that they'll be addressed through the pilot, and I'm curious to see how this will develop.
Thank you very much, Chris. Yeah, it's all about the details, isn't it? And you've laid that out very clearly, what they need to consider. And obviously, we know the NHS is not great with data, so let's hope this pilot really sorts that out. Okay, I have another question for Cheryl. Um, so, as we know, recruitment is ongoing at the moment for the National Director of Patient Experience. What do you think should be at the top of their to-do list?
And before I even delve into that, I hope that there's a patient as part of the interview panel. Don't know, but I think that would be really important, and a segue into showing that it's not just a tick box exercise, which we don't want. You know, patients always use that terminology, tick box exercise. We're asked surveys all the time, we're asked for information all the time, we're asked for data all the time. But I think for me, what I would say to the National Director of Patient Experience is don't ask questions if you're not going to do anything with the feedback. That's like flat line. It's don't come in and just, I don't know who that person's going to be, but I mean, we've got some great big hitter charities out there, but we've also got some smaller charities who are desperate for funding, who are actually doing the groundwork, who really know what is happening in their communities. And I think it's not just about coming in and sitting at the leadership table and looking at the data that you've seen before, or, you know, and how are we going to look at this from an analytical performance target database. One of the things that I would love to see is that person go into the communities, actually listen to the people who this is affecting. You can make decisions at boardroom all the time. You know, we're all educated people. We know that we need leaders. We understand that, but it all happens on the shop floor. If you don't know what's going on the shop floor, the decisions that you're making are still going to have red lines through them when it reaches the patient, if it's affecting them. So let's not waste time. Let's not waste resource, but really get into the heart of what's happening in the community. And I hope going forward that whoever that patient is, and I really do hope that there is some kind of communication between the director of patient voice and a real patient that can actually still keep everything aligned. And yes, you've made that decision, but actually maybe have you really looked at that? So yeah, two things for me. We're not tick box exercises, and don't say something that you're going to do if you know absolutely that you can't do it. That's me.
Great. Thank you so much, Cheryl, for that. A lot for the new person to do. Okay, moving on to Rachel. So the health bill is currently working its way through Parliament. How do you think it's going to impact patient voices? And what is the one thing you'd like MPs to know about when they're debating the bill?
Well, we've already been in front of the committee debating the bill, and the one thing that we are absolutely concerned about is the loss of the independent voice. And Chris covered that. There are a few other small things that I'm concerned about, but if I'm going to focus on one thing here, I think that is that I want MPs to hold on to is the patient voice. Cannot be an afterthought bolted on. And Cheryl, I think everything you said is so valid. This example, you know, patient experience isn't customer experience. This is a really personal relationship. You know, yes, there are bits that look like a customer experience, but the loss of Healthwatch, the loss of that independent voice is something that we've raised with MPs and members of the Lords. And I have, from the very beginning, since that came out, I have been trying to correspond with people in the system to say that you can't be marking your own homework. If you're sitting within the department, sitting next door to your colleagues, there has to be a statutory provision that you report on what you want to report on. But the independent voice at a local level has to be maintained, and has to be laid into it. And people are asking about PPGs in the chat box. In the questions as well. I think PPGs need to be given more strength, but they're not in the 10-year health plan. They're not in the NHS modernisation bill. So what I'm very much asking somebody in the chat is saying, lobbying their MPs to keep Healthwatch. I think it's going to be quite an interesting time as the modernisation goes through the Lords. And I think it will take much longer than was previously thought for the timeline for this bill. So it's, as you reform the NHS, we cannot let the patient voice be the thing that falls, the independent patient voice be the thing that falls between the gaps. And it needs to be built in now into any amendments with the bill. And that's my worry, the independent patient voice.
Thank you, Rachel. Yeah, absolutely. And then I have a question for Chris. So Chris, this is about technology again. How do you think the NHS app can be used to gather and analyse patient feedback? And what do you think are some of the challenges related to this? And also for the plans for having analysis supported by AI?
Yeah, I could talk about this all day, but I promise not to. First of all, I think there's real potential in the technology. The NHS app's got a user base, something like 38 million, which is huge. Loads of people have it installed. At its best, potentially that creates a new way to communicate back and forth between patients and their providers in the wider system, which I think could be really, really valuable. I think the easiest way to use it, the easy end of the idea shelf is just to push surveys through it, right? And have people respond when you prompt them and then not give anything back on that. But it's also the least edifying and the least satisfactory for patients. It doesn't recognize the value of the technology in any way except as a cost saver. And I think if you want to make good use of it, you've got to treat it as a platform for communication rather than as another reporting tool to add to the collection. So I think it needs to be thought about in a different way to get the most of it. The kind of model for this that I quite like is something like care opinion, where people can make comments about their care, see responses from members of staff, and then be told when a change is made based on their feedback. You know, I think that kind of model is something that we should be looking at getting closer to, rather than simply replicating surveys that are already present and already far more robust than they're likely to be through the NHS app. The flip side of this is, where are the challenges? There are a few questions in the Q&A about digital exclusion, and that's a really, really good point. There are people who are not online, not using the app. They're disproportionately older. Those people are disproportionately higher users of services as well. So the risk is, if we rely too much on feedback through an app service that skews towards the people who have the lower need, well, that just supports an inverse care law, doesn't it? Where the people who need the most care have the least stake, the least voice, and their needs are less well met. So we've got to be really, really careful about that. And we've got to continue to hear from the people who aren't going to be part of the app. That means going to people where they are. That means asking for their feedback in a way that suits them. Ideally, it means having independent advocacy close to people to allow them to share in a way that suits them. And then beyond even that, there are a lot of, I think, technical questions to overcome. You know, huge install base, 38, 40 million, as I said. But how many of those people are using the app regularly? How many of those people have got push notifications on from it? If ask honestly, when was the last time you used the NHS app? When was the last time you logged in? The responses vary quite a lot. So there's a lot of possibility. I'm really excited about what could be achieved with it. But there are a lot of pitfalls along the way, and we need to be really, really careful.
Thanks very much, Chris. And you mentioned there about digital exclusion, which I think a lot of the people in the Q&A have talked about as well. I wondered, Rachel or Cheryl, did you have any thoughts about how we can kind of work on that and make sure less people are excluded, or what we do, the people who are digitally excluded, I guess?
I think there's nothing wrong with looking at, you know, the shiny magpie, you know, the digital stuff, the AI stuff, it all matters. And there are certain areas where it's making a really big difference. The ultimate word is balance, right? We are leaving people behind. If you can see already that people are struggling what are we doing, to really think about, okay, if we're going to change this, how does it affect this person? I think sometimes when we look at the advancement, it's like, well, we've done all of this and it's just sent out to everybody. And it's like, well, hold on a second. Did you actually check this with anyone? Because why is it only now that you're seeing that it's not working? So I think there's still, once again, that parity of, we don't have the patient involvement at the times. You're making decisions about things digitally where the patient is still excluded. And then we go back 10 steps because we now have to fix something that we hadn't thought about before. The worst thing possibly for me from a digital perspective is seeing news arriving on an app when I haven't even spoken to my consultant. That's the worst thing that could ever happen. And I still think we don't have an answer for that. I'm not a digital person, I'm not a digital expert, but I know when something's not working and when it's not right. So I hope that we are able to look at those gaps a lot more with what we've already got, instead of keep pushing the narrative forward that we need to be digitally this and digitally that. Betty, who's living in Skegness, who's 89, doesn't have any family around her, still needs to get her to appointments. Are there digital champions in the area that she can pick up the phone and go to? I don't think that there are. So, there's so many questions and lots of things where I just, like I said, for me, it's sometimes the digital aspect is like a magpie. Let's go forward and do all of this lovely stuff. And then we've left people behind. I think there's also an assumption that it's just older people. I think the younger people coming up as well, it doesn't necessarily mean that they're all into it either. We make lots of assumptions that it's that 80-year-old plus that doesn't understand what's going on. It's difficult. It's very difficult. I had a issue yesterday. You have to have a password for that and a password for that and then a password for that. I can't remember everything. You happen to write everything down. So it's there's lots of technical difficulties. And I think when you're building digitally an app, the person that's building it is because they're educated in it. So they're not going to understand that it doesn't work for everybody else. So lots of work to be done, unfortunately, on that side.
And I think I'd only add one point, because you covered everything I would have said, Cheryl. And I think it's the point around shared decision making that I made earlier on, and that's part of shared decision making. How are you going to receive your service? How are you going to receive your news, your diagnosis, your test results? That should be starting at the very beginning of your relationship, your consultation. And actually, are you at a point where now, loads of people put in the chat around digital exclusion in young people, and Cheryl, absolutely, the whole thing about older people can't do digital winds me up something rotten, because I have family members who are well able to, but some aren't. But I think it's making sure that people can access the services in the way that works for them, and that digital this great, and I'm pro it, doesn't leave people behind. And you could look at it, if people who are very confident with digital are using that route, it should make more space for those people who actually need to access services, and I think in a different way, and receive information in a different way. And I think that's the way we should be planning it.
If I may briefly, I think that's a great point, and it's fundamentally about choice and control, which really speaks to that issue of patient power. Individually, everyone should have as much control as possible over every decision in their care, right down to, how and when do you want to receive test results? Do you want to have a conversation before you get them? Do you just want to see them as quickly as you possibly can? It shouldn't be impossible to make those distinctions in personalized care that much for individuals, because that's what real power looks like. That's what putting patients truly at the heart of things looks like. And it feels radical because it's a long way from where we are. But if we want to fundamentally shift power to patients, that's where we need to get.
I think if I can just bring one more point in all of that as well, is don't forget, even though we're talking about patients, we are still people. There are plenty of patients that I've met who worked in the digital field, have come from government, who, have a diverse range of skills and expertise. And so just because I'm a patient at that moment in time when I walk through the hospital door, I still run a consultancy. I've still got stuff to do. I'm doing what I'm doing because I understand maybe the business operational side of things. So let's not forget that patients are still people, and yet that experience, that lived experience, is about understanding what is happening to them and that they can actually help. So ask the patient who has a technical background.
Yeah. That seems like a very sensible thing to do. Thank you all for your thoughts on that, because that's something that's really come up in the chat and on the Q&A. We only got a couple of minutes left for questions, so I'm going to actually just try and have a very brief question, which someone has asked in the chat, which is about the 10-year plan and implementation. And is there anything that is showing progress around implementation? Do you know of any of how people can find out about that?
And I think, if I jump in again, I work very closely with my Cancer Alliance, right? So I'm very blessed in that way, that even just the conversations of getting our patient partners in one room and actually summarizing the 10-year plan for those patients, that was so helpful, because it's a massive document. Not everyone's going to understand it. So having the MD in the room with the patients, explaining what it was going to mean for them as patients, working with a Cancer Alliance as to how the 10-year plan can affect them, was really, really helpful. So I think just being able to take things into small piecemeal and breaking it down, it would be like really helpful for patients as well.
Rachel, Chris, do you want to comment at all?
Well, I think we're all a little quiet to begin with, because simple answer is no, that there's no published implementation plan. We kind of anticipated that there might be a delivery plan to follow, but there hasn't been yet. So you have to kind of put together information from lots of different sources, I'm afraid. And I'm sure that there will be a plan at some point to issue an update on progress, but we're waiting to.
Yeah, I think so. And I wonder, Chris, maybe you and I could, for people on this call, pull together where we think, and maybe and Cheryl into a very short blog about where we think it's come to. There are good stuff happening. There's a lot happening around kind of the director of patient experience, and we need a real disruptor to get that job and get in there and get that really working for the way that we all believe it needs to work. There is new appointments within the department, but and I think there's a lot happening around kind of patient experience measures, but it's slow progress. But then it's slow progress because we built in a reform with it, which nobody was expecting. Maybe I was naive, but I wasn't expecting the reform that's happened, and the abolishment of NHS England and Health Watch. But I think we do have, we're going to have a new Prime Minister. We probably know who it is. And I hope that when the government gets back from recess in September and that's kind of settled, we'll know who the new Health and Care Secretary is. Because right now it all feels like James Murray's there, but is he there for long? And at the moment, we need to work out where we can put that energy to say, actually, this is what needs to happen next. But I think that's our roles. So we will keep you informed.
Great, thank you. Okay, so we've come towards the end of the webinar. I want to say a huge thank you to our panelists for really, really powerful points and discussion, and a huge thanks to the audience as well. You've been brilliant commenting on the chat and some really good questions. And I think we probably needed about 5 hours to do this instead of just an hour, but there's never enough time. I think to kind of summarize, some takeaway points for me is the feeling that, patient voices have started to become more prominent, but obviously there's so much more to do. And that poll at the beginning really showed that people don't feel that patient voices are having an influence. And that we really need to look at how we can avoid tokenism, and remembering that, collecting patient experience is not the same as patient involvement. It's just data collection, as Chris said. And really challenging the healthcare services to listen, but not just listen, to create change, and to trust patients to make their own decisions and really address paternalism, and making sure that we're not leaving certain patients behind as well when we're doing this. And I really wanted to end on a positive note, and I'm going to use what Cheryl said about hope. I think this is an exciting time, and clearly there's lots to do, there's lots of detail to be done, but things are changing. So we really hope that in a year's time we might be back here showing that there's been some progress, certainly in 10 years' time anyway. So thank you very much, everybody. I think we do have some closing slides. Yeah. So a huge thank you to the sponsors for letting this happen today. Also want to let you know that to the audience that we're going to be sending you a link with a recording of today's discussion. So please do feel free to share that with your colleagues. And they're also going to send you a very short feedback survey, which will just take a couple of minutes to fill out. So please do fill that out if you have time. So yes. Thank you very, very much. And there's a bit more information on the Patients Association here. Thanks, everyone. Have a really great day. And thanks again for a really brilliant discussion.